There, it's cool. The double echo, I know. I'm gonna go I guess I'll just go sit in my car.
Wait, I can't even make this pop. Where's my?
Hmm?
I can't work your mouse.
This is all you have to do.
Okay. But I also, where's my, how come, there it goes.
Yeah.
This wasn't. And then which is the button?
Press that button. Oh,
The other side. No,
the top one on your finger. There, that one.
there's a button there. Oh. You need to fix my.
There you go. Sorry.
And then participants.
You got 6 minutes. Okay, I have 6 minutes.
Okay, good morning, everybody, mid-morning. I hope folks can see me at the top of your screen and as the small person. My name is Claire Courtright. I'm the policy director for Cal Voices. And in just a couple of minutes, we'll get started with the quarterly policy update. This will be the first update, of the Access program. And I'm going to give it just a couple more minutes and let folks join. And then I'll repeat some of what I just said, and we can get rolling. Think we're right at 10 o'clock, so I'll probably give it 30 more seconds since I need to manually let folks in, and then we can start the presentation. Okay, we are right at after 10. So I'm going to go ahead and get started. I'll reintroduce myself. My name is Claire Courtright. I'm the policy director for Cal Voices. I'll do a little introduction to Cal Voices, but I think most people on this call probably know of us, and a little introduction to the Access program at Cal Voices, which is a new program in partnership with the Mental Health Services Act Oversight and Accountability Commission. And the purpose of the Access program is to really lift up the peer and consumer voice, the most primary stakeholders in the behavioral health system, to enable some advocacy at the local level. All right, well, I'll have to keep admitting people as we go along. This session is being recorded. There will be time after the presentation to ask questions. I would ask that you try to hold your questions if you can until the end, because I'm not at my usual setup, so it's difficult for me to manage seeing hands up and a chat and all that while I'm also presenting. But there will be ample time at the end, hopefully, for questions and comments regarding the material. So if you're not familiar with Cal Voices already, we are California's oldest peer-run organization, and a peer-run organization is an organization run by and for people with mental illness or their family members. We are a direct service provider, so we provide peer support services. We employ peer support workers in the counties around Sacramento. We're based in Sacramento and in Sacramento itself. We're also an official state of California training entity for peers who want to get certified to be able to bill Medi-Cal for their peer support services. So we have that through Wise University. And we do policy advocacy. As the policy director here, I'm mostly focused on statewide advocacy. So I'm at the Capitol a lot. I'm working on, the big bills that are moving through the state. But I will say that, especially lately, that state advocacy has a particular county focus and local focus, because even a lot of the large changes to policy are being implemented at the county level, and there's lots of work to be done in that implementation process, and therefore lots of opportunity for advocacy for you all. So this is a really good time for us to be starting the Access program. I'm an attorney. I'm a person with lived experience of serious mental illness. I've been a peer support provider, and I represented a lot of folks in the involuntary system prior to joining CalVoices. So an introduction to the Access program. Access is a 3-year program of CalVoices, but it may continue after that. And the purpose, as I said, is to really elevate the voices and needs of clients, peers, and other primary stakeholders so that they can participate fully and genuinely in the behavioral health policy decisions of California's public behavioral health system. We also coordinate with local organizations. So the Access program is actually networked throughout the state with 17 different local level entities that are either directly involved in providing services to people with serious mental illness, or this is an interest area for them. And there are a variety of organizations. Some are peer-run orgs, some are legal aids, some are doing decarceration work. So it's a great group of folks. Got to admit some more people. Okay. So I'm just going to jump right into kind of the meat of this. And I will say, for folks that are very familiar with mental health policy already in the state, some of this is going to be, sort of basic and a repeat for you, but I did put in some content that drills down a little bit more on some of the big policy changes happening that will hopefully be useful. As we go forward, we're really going to have more of a focus on Prop 1 implementation and possibly Senate Bill 43, which is closely related to Prop 1, since those are the biggest changes, and they also are the biggest opportunities for local level advocacy. So, most people, this is total review, but obviously the big things driving mental health policy in the state right now are the state's homelessness crisis and its perceived connection to serious mental illness, but also substance use disorder, very much increasingly substance use disorder. Another big driver of policy at this time, and it was definitely a factor in Proposition 1, is just secular changes in California's economy. California is going through a period where things sort of can't continue to go up in price. We know the housing market is what it is. Tech is way down. The state is facing its biggest budget deficit since the 2008 recession, and that is going to be a big driver of policy. They expect those budget deficits to continue into the next couple of years. So that's going to be a major factor in policy, and is currently and was in Prop 1 and going forward. There is also a major driver of policy is tensions between the state and counties. If you are familiar with the administration of behavioral health in California, the state delegates down to the counties to actually administratively perform many state functions, including administering Medi-Cal at the county level, particularly for folks with serious mental illness in what's called specialty mental health. So your provider, is the county who is managing Medi-Cal and managing those providers and managing your benefits. So this creates quite a bit of tension between the state and counties, both over who has to fund what. Counties have their own sources of tax revenue, so there's long-standing tensions between the states and counties. And if you watch some of these press conferences or different things coming out of the governor's office versus the counties, you're going to pick up on that tension. So that is also partially driving policy at this time. And then to some extent, the state has been sued for a number of things, and I won't go into that, but lawsuits do change policy as well. So what is changing with respect to mental health policy in California, just the big picture? Medicaid, both at the federal level and in California, people are looking at Medicaid, which we call Medi-Cal in California, and saying, can it be more than health insurance? We know social determinants of health are a thing. We know that, housing in particular, or your socioeconomic struggles play a huge role in our health. So there has been a push to look at Medicaid as more of, to look at health, as a broader concept, and to fund more things that you wouldn't traditionally see health insurance fund. And so right now in California, that big expansion is really on what we call the managed care side of the house versus the counties. So you will see large managed care organizations like Kaiser or Sutter, administering some of this. It's called CalAIM. And CalAIM has a bunch of waivers, which are temporary funding arrangements, temporary funding provisions with the federal government that is allowing them to fund a variety of services, including things like transitional rent, some services that are being performed in jails now, different things that Medicaid was not providing previously. However, those may or may not turn into permanent aspects of Medi-Cal in California or permanently funded types of programs. So, but that's a major thing that's been happening. So if you've heard a lot about CalAIM, that's sort of what's going on with CalAIM. Then we also have the Behavioral Health Services Act, previously called the Mental Health Services Act, which was part of Proposition 1, which was a ballot proposition that passed just this March, just about 2 months ago. That is a major source of funding for the counties, and we're seeing major changes to that source of funding, and that's what we're going to focus on going forward. Another large policy shift that we're seeing is really the marriage in policy of serious mental illness and laws relating to serious mental illness and substance use disorders. So what that looks like legally is you're going to see a law that used to only apply to people with serious mental illness, and they've put substance use in there as well. And now those populations are going to be traveling together in funding sources. They're going to be traveling together in laws relating to involuntary treatment. There really is, and you see it everywhere if you do legislative work, that we're looking, the law and the funding sources are looking at SMI and SUD as things that move together. We're also seeing the greatest expansion of involuntary treatment law in about 60 years. Many of our laws relating to involuntary treatment have changed in the last 2 years. And these are massive shifts, and I will go over some of what those are. And then there's a big push in California to build infrastructure. We know there's various, have been funded in the past, various programs to build permanent supportive housing or build low-income housing generally. The new push in infrastructure really over the last 2 years, which is kind of more coming into public view, is building clinical treatment facilities. That's a huge push right now. It's called the Behavioral Health Continuum Infrastructure Grant Program, or BCHIP. And it is going to build a lot of clinical treatment facility beds. We're also seeing new jails in various counties that are focused on people with serious mental illness. So we may have a proposition for a new jail that is only for people with serious mental illness, possibly substance use disorders. And so we may talk a little bit about the tension between, clinical treatment beds versus permanent supportive housing versus housing that does not fall into the category of permanent supportive housing, but it's a permanent place to live. So again, a lot of that clinical treatment facility beds funding is coming out of Prop 1. It was one half of Prop 1, AB 531, an infrastructure bond that gives some money to BCHIP. So I just want to zoom through kind of what has happened over the last 2 years so that people have a sense of orientation on what's going on both at the state level and what is not just trickling down, kind of a fire hose down to the counties to figure out how to put it into action, how to implement it. So obviously everyone is fairly familiar, at least with the name of CARE Act or the CARE Court, and that passed in the 22 legislative cycle. So this is a law that, really has only been go live in California since January 1, and only in 8 counties. And then we also had in the 21-22 session, the trailer bill, the budget trailer bill that created the behavioral health continuum infrastructure program that got an initial $2.2 billion. And we'll talk about what that is building to date. Then there was a number of laws related to involuntary treatment. We had a second 30-day hold added to the involuntary holds the series of involuntary holds a person can be placed on. We saw some changes with our ERs with AB 2275 with Wood. Importantly, the state updated a facility license class called Chemical Dependency Recovery Hospital. And it looks like that's where our folks who are going to be on involuntary substance use disorder holds are likely to end up in a facility of that nature. And we'll talk about the fact that now, as I said, SMI and SUD are running together. So that was one of the big changes that we'll talk about, is the ability to place folks with only a substance use disorder on an involuntary hold or under conservatorship, which requires locked facilities. And also we had a change to AOT, our assisted outpatient treatment law, also called Laura's Law, in 21-22 cycle. So CARE Act, if anybody's not familiar with it, it's basically a form of AOT because it is an outpatient civil commitment order. That means although you're not in a locked facility, you are under a court order to engage in treatment. These are the basic criteria. How it's different than AOT, you'll see the last 2 criteria are exactly the same as AOT, but basically we're looking at folks who are adults with a schizophrenia spectrum disorder diagnosis. That doesn't include, PTSD, bipolar, major depressive disorder with psychosis. It's just things like schizophrenia, schizoaffective, etc. And then the minimal criteria is really you're not clinically stabilized in ongoing voluntary treatment. So then the court, it's a little different than AOT because AOT was really focused on perceived threat of violence from folks and has extensive and higher criteria to be in court. CARE Court's much lower. And CARE Court is a little different in that it's very explicit in CARE Court that the court can order you into housing of some nature, a housing plan. So without meeting, the usual legal criteria that you need to do that, which is a conservatorship. So CARE Court is one of the things we're told is responsive to the homelessness crisis. And one of the ways in which it may be responsive is to, the court having physical jurisdiction over where you are physically, right? So are you on the street or are you living in this place under a court order? It's also different from AOT in that family can petition, a number of your roommate can petition, a number of parties can petition, and then the county gets subbed out for you. So essentially, this is part of the state-county tensions. The state felt the counties weren't using their involuntary treatment laws enough to deal with homelessness. And so they put this substitute petitioner process into CARE Court so that, the counties have to pursue CARE Court orders in some instances when they're initiated by someone else. Also, a big policy question is where's the funding going to come from for the services and the housing for folks that are under CARE Court orders? CARE Court funded the court system. It funded the administrative aspect. It did not fund services or housing. There was no money for services or housing in the CARE Act. And so the CARE Act is really going to have to rely on other sources, other public sources of funding, which mostly means Medi-Cal or MHSA funded services like full service partnerships in the Mental Health Services Act. So then we had the Behavioral Health Continuum Infrastructure Grant Program. Again, an initial $2.2 billion. The initial round of funding did not only build infrastructure, but it was primarily to build clinical infrastructure. And so here is what has been funded to date. It doesn't mean these are completed projects. It just means the money has gone out the door to the county, tribe, or private entity that is going to construct these beds. And I think the big thing everyone wants to know is what kind of beds is California constructing? Are they constructing locked beds, or are they constructing unlocked beds? Are they constructing short-term hospital beds? Are they constructing residential beds? You know, what are we building with all this money? So you can go over these slides in detail at your leisure, but I will say, you know, we are building a number of new psychiatric hospitals. Those are locked facilities. We're building a lot of SUD residential. We don't know how much of that may be locked or unlocked. We're building mental health rehabilitation centers. That's a facility license class that could be locked or unlocked. Same with psychiatric health facilities, same with crisis stabilization units. Most of the rest of the infrastructure should be unlocked, but we're not sure. And I'll explain to you why and why there's opportunities for advocacy around the new BCHIP money that came out of Prop 1 and where that might go. Again, this is the same infrastructure slide as the previous one, but by number of beds. So we're building 320 new psych hospital beds, quite a bit of adult residential SUD, but we're not sure, you know, is that locked or unlocked infrastructure? You know, just about as many MHRC beds as acute psych, and a goodly number of puff beds, and it's odd that they did the CSUs by slots rather than beds, so I'm not exactly sure what's up there. But for folks in the peer community, one of our big concerns is that there be adequate voluntary unlocked infrastructure, and that we not see our entire system morph into a locked system where folks can only access services if they're under some kind of court order, or have, you know, no access to the voluntary system. So the only door to access is through the involuntary system. We're seeing shifts in that direction that are concerning to us. And that's obviously a point of view of Cal Voices and the peer community, but not necessarily of the Access program. So another thing we saw happen in the 21-22 cycle was we added a 30-day hold for grave disability. So now the quote unquote short-term holds in California can total 77 days. Some counties also interpret the second 14-day hold for danger to self to be something that can precede GD hold. So you could get up to 91 days in some instances. So we have a 72-hour hold, 14-day hold, 30-day hold, and this bill in 21-22 created a second 30-day hold. Whether or not this is in your county can vary. If your county chose not to adopt the 5270.15, the original 30-day hold, then you also do not have the second 30-day hold. However, if your county board of supervisors did adopt the first 30-day hold, then you automatically have the second one. So this could be a point of local advocacy if if your county is considering getting a 30-day hold and they don't have it now. However you come down on that issue, that could be a point of local advocacy. We also had a change to the situation in our ERs. You've probably heard that folks on involuntary holds are often stuck in ERs. Why that is can vary. Sometimes it's insurance issues, but it is true that our folks are not supposed to be in ERs when they're on psych holds unless the ER is designated to provide that psych treatment. So these undesignated ERs, because they had an inability to place people on those longer term holds, they would just write one 72-hour hold after another, sometimes for weeks, sometimes for months. And those patients were stuck without any what we call due process, which means access to the court system to challenge what's happening. So this was actually a good law that said, hey, we've got these folks stuck in ERs and we have to at least, because of some federal precedent, a federal lawsuit, we have to, it's an older one, but it got applied. We have to give these folks a way to challenge their holds and say this, I don't meet the criteria to be on a hold and I need to get out of this hospital. So this AB 2275 made sure that the folks stuck in ERs, that the local PD and the patient rights knew they were there. There was a notice requirement, and also these folks had a right to have hearings to get out of the ER. So that was a good law that has somewhat helped the situation with folks stuck endlessly in ERs and nobody knows they're there. Chemical Dependency Recovery Hospital, as I mentioned, this is the likely facility licensure class that is going to become sort of the SUD version of a psych hospital. So BCHIP is actually funding, I believe, several chemical dependency recovery hospitals, but it's clear that is an eligible facility licensure class to be funded through BCHIP. We've seen some Department of Healthcare Services regulations saying that chemical dependency recovery hospitals are a place where folks on involuntary SUD holds can go. And they can be co-located within a general acute care hospital, a psych hospital, or a CSU, as long as they qualify as distinct subparts. So for folks who are scratching their heads as to, what's the future and where will people on SUD holds go, it's looking like at least one place is a chemical dependency recovery hospital. Let me check my time because I talked too much. Okay. We also had a change to AOT in the 21-22 session. AOT is also a civil outpatient commitment order like Care Court. It's much older. It's been around since 2001 or 2003, early 2000s. It was not in many counties because the counties got to choose. Am I going to do AOT or am I not going to do AOT? So this is also part of the state county fight where the state is sort of pointing at the counties, blaming them for the situation with the unhoused and wanting them to use these involuntary programs more. So one of the things they did to do that is previously your county had to explicitly opt into AOT, meaning the Board of Supervisors had to adopt a resolution and say, yes, we're going to do AOT. And then you would have it in your county. I think very few counties opted into AOT either because they didn't agree with it philosophically or they didn't feel it was necessary in their county. This bill changed the county opt-in to a county opt-out, which meant the Board of Supervisors had to explicitly say, we don't want AOT in our county. And if they didn't say anything at all, the county had to implement AOT. My understanding is about 20 counties out of our 58 have now implemented AOT. But I'll go back. AOT suffers from the same problem as Care Court, right? It doesn't have any funding for the housing or the services that a person in AOT is entitled to, at least as a plan, right? At least as a treatment plan, they need to consider this. It's also a little different from Care Court because AOT actually has folks who are under a court order in AOT have a right to specify types of treatment services, and you don't in Care Court. So I may do at some point a training AOT versus Care Court that I think would be really interesting. But in some, AOT kind of suffers from the same problem as Care Court, which is no funding for services or housing. And so they're really looking to those previously all voluntary budgets like Mental Health Services Act to fund folks that are in these court-ordered programs, to fund the treatment and services for folks in court-ordered programs. So last year, 2022-2023 cycle is where we saw huge changes. We saw the redefinition of grave disability, massive changes to the Mental Health Services Act. We saw more funding for the Behavioral Health Infrastructure Bond Program. And honorable mention to a change to patient privacy, medical records privacy. I'm not sure I should say it quite like that. There was a change to Care Court where essentially a county could share your medical records with the court, or private, if your mental health provider wasn't the county, it was a private practitioner. The private practitioner might be compelled to give your medical records to the county and then the county to turn them over to the court without your consent or knowledge before you're in the case. So it was not a good bill. It has some real problems with HIPAA, the federal privacy law. It's another thing that happened in the session last year. So we'll dive in because most of the local level implementation opportunities are going to come out of SB 43 and out of AB 531 and SB 326. So first of all, the redefinition of grave disability. Grave disability is one of the criterias under which you can be placed on an involuntary hold and in a mental hospital in California. It's also the basis of a conservatorship. The only basis of a mental health conservatorship is grave disability, and grave disability, you know, we call it the front door to the mental institution, because once you're placed on a quote unquote permanent conservatorship, as gravely disabled, which is limited to a year, but renewable indefinitely, that is the necessary legal prerequisite to placing folks long-term or even medium-term in locked facilities. So this is a very important change to the law. And what SB 43 did was change the mental health law. And now it reads that grave disability can mean due to a mental illness, the inability to provide food, clothing, and shelter. That was the old definition.
That was the old one. Unmuted. But
somebody unmuted and now I've got an echo. Can you check to make sure you're muted? Thanks. So I should back up. That was not done well. So grave disability previously meant due to a mental health disorder, you couldn't provide for your own food, clothing, and shelter. This law changed it. So now grave disability means as a result of a mental health disorder or a severe substance use disorder, you can't provide for food, clothing, and shelter, or you can't provide for personal safety, or you're unable to provide for necessary medical care, or all three. It also removed a fairly important evidentiary rule, which will bore anybody who's not an attorney, but it was an important rule that kept hearsay out of conservatorship cases. It was established by our California Supreme Court. It applied in more cases than conservatorships. It applied in criminal cases, and it was removed just from folks that are facing conservatorship. They no longer have this hearsay protection. It also, SB 43 also created some data reporting requirements related to involuntary holds. That data should be out pretty soon, and we'll be looking at it for to see the actual scale of involuntary interventions in California, because we did not have good reporting previously. So obviously this is a sea change, right? Because we have never put folks with severe substance use disorders on involuntary holds or conserve them in California. There was an attempt to do so with chronic alcoholism in the past, and it fell apart for various reasons. But we've never done it with respect to opioid use disorder or marijuana use disorder, or the broad spectrum of substance use disorders that now are holdable and conservable in California. We've also never used personal safety as a criteria or necessary medical care as criteria to place people on involuntary holds or conserve them. And so, you know, even just with a small amount of thinking, what does this look like? You realize we don't have the appropriate facilities, right? Because a mental hospital isn't a place that can also treat cancer. And a mental hospital currently is not a place that can do medical detox for a severe substance use disorder. So it's obvious that we lack the appropriate facilities to support this law. Oh no, why am I having trouble? Okay. So this, again, you can review this at your leisure. This is the actual new definitions. They have some more detail as to what severe substance use disorder means, but you should notice that it relates to the degree of substance use and not the type of substance. So, you know, again, marijuana is covered, opioid, alcohol, anything in the DSM as a substance use disorder technically is covered by SB 43. Personal safety is defined as the inability to survive safely in the community. How that's being interpreted is very concerning, and we'll talk a little bit more about that. It's also an opportunity for local level advocacy and necessary medical care, and how people are going to interpret that is important as well. So SB 43 implementation, again, because of the obvious lack of physical infrastructure, lack of buildings, you know, we don't have the staff trained up. We don't have regulations for what safe and legal care is on an involuntary basis for SUD. So really there was nothing to support implementation, immediate implementation. This law passed in September and last year. And then, you know, technically it was effective. Its effective date was January, several months later. So there was placed in the bill the ability for counties to delay the implementation of this law until no later than January 1, 2026, because nothing's in place. So what ended up happening, again, this was state county tension. The governor really wanted the counties to just plow ahead with implementation. 56 of the 58 opted not to, because they felt it was not possible. So we have only San Luis Obispo County and San Francisco counties that opted for immediate implementation. However, that does not mean that right now folks with serious substance use disorders are actually being placed on holds. The new data that just came out, maybe even today, will let us know if anybody is at this point, but it means really these counties are put pedal to the metal to try to figure out how the heck they're going to implement this whole new schema. And what we have seen out of San Luis Obispo County and to some extent San Francisco County with respect to implementation is very concerning. There are stakeholders that would not like the way that these laws are being interpreted. And because the counties have a great deal of latitude to come up with their own legal understanding of what these fairly broad definitions mean, right? So if we go back a slide, inability to survive safely in freedom. Can you think of 100 different things that could mean? It's up to the counties to a certain extent. What that will mean, necessary medical care, also to a certain extent up to the counties. So what we're seeing is in San Luis Obispo County, inability to provide for personal safety is being interpreted as crime victimization. If you were the victim of a crime and it's perceived that you somehow placed yourself in a vulnerable situation or were vulnerable due to your, failure to treat your SUD or serious mental illness or any mental illness actually, then that can be interpreted as a reason to place you on an involuntary hold. That's very concerning. I know a lot of victims' rights advocates, sexual assault survivors would be very concerned with that interpretation. There are other legal interpretation problems, which means you're going to see variation throughout the counties. I may highlight some of those. And in webinars later, I'll probably drill down specifically on this law because you do have the ability in your community to influence what it might mean or how it's implemented. Again, the lack of specialized facilities for SUD or co-occurring serious medical condition is something that has sort of been dumped in the lap of counties to figure out. And also this bill has not been tested by litigation. So what that means is, there are opportunities where, let's say if you were conserved for a substance use disorder because, you were the victim of a crime, and you decide your public defender is outraged and so are you, and you decide to appeal that decision up, right? You can say, well, I think there's constitutional problems here. I think there's other legal problems here. And sometimes people win those and it shapes the law. So I will say, because this law hasn't been implemented, it hasn't been shaped by the courts yet. So it may end up meaning different things in the future or having a more consistent interpretation across the state. But for right now, it's kind of like the Wild West of what does this mean? So again, the local advocacy opportunities here, and we will try to give you some more detailed information and guidance in the future, is the decision makers at your local level who are making policy interpreting this law. And so to whom do you want to speak if you have concerns about this law? You want to talk to your county board of supervisors, your behavioral health director. It's going to heavily be the behavioral health director with backup from the county's lawyers called county counsel. You want to go to your mental health board, your alcohol and drug advisory boards. They are also the entities that are going to have the most specific information to your locale, specific to your county, as to what's going on, how this law is interpreted, and how it's likely to be implemented in your county. There's all kinds of issues one can think of. Is the county going to actually try to create involuntary treatment centers for the whole range of substance use disorders that are covered by the law? Are we going to have marijuana use, disorder treatment facilities and alcohol and opioid? Are we only doing some? What are we doing here? Whether this new standard applies to minors, I feel very strongly legally that it should not and does not the way the law is written, but San Luis Obispo County is interpreting these new substance use holds and substance use conservatorships to apply to minors. What types of facilities are we going to create? Are we going to create dual use facilities that are psychiatric and SUD? Are we going to convert existing facility types? What's happening with the conversion of infrastructure or the use of infrastructure in your county? Those are county level decisions. And there are many more. And I'm sure that if you are involved in that, if you're interested in the subject and you're involved deeply in listening and in that dialogue and meeting with folks at the local level, your advocacy will take its own shape as you see what's happening and the range of decisions and discretion that's happening. And then on to Prop 1. Proposition 1 was on the ballot, on the primary ballot on March 5th. It did very narrowly pass. I think it passed by somewhere between 20,000 and 40,000 votes in the 7 million vote election. It was on the ballot because it fundamentally altered the Mental Health Services Act, which required those alterations, SB 326, to be taken back to the voters. It was also on the ballot because it contained AB 531, which was the state of California borrowing money to build more clinical treatment facility beds. Bond borrowing has to be approved by the voters. So both of those measures had to be on the ballot separately from each other, but they were placed together as one measure on the ballot. So obviously, well, maybe not obviously, depending on your level of familiarity, but SB 326 fundamentally altered the Mental Health Services Act. This is a major source of funding for your county for the public behavioral health system. So public meaning either you're in specialty mental health with Medi-Cal for the county, you're a county client for mental health, or you don't have Medi-Cal or public health insurance, but because you have a serious mental illness or you're a family member, you qualify for services under the Mental Health Services Act by reason of your diagnosis and impairment, not your insurance status. MHSA was not insurance money. It was a direct source of cash to the counties. It was a grassroots voter ballot initiative. So back in 2004, Rusty Seelix, who was with Mental Health America and a longtime mental health advocate, with the help of Assembly member Daryl Steinberg, and the community, heavy community involvement, wrote this bill and put it directly on the ballot for approval because they couldn't get it done through the legislature. And what that bill did was levy a 1% tax on personal incomes over $1 million. That money is the Mental Health Services Act fund. It gets distributed to the counties. And then the counties, using a community planning process, can enhance their services and programming, and it's county specific. So there are broad regulations that say, you know, your programs and services must fall into certain categories. Other than that, the local communities get to decide what programs and services they want in their community. So the counties all vary widely. And MHSA is a very important piece of funding for behavioral health services. It's 30% of all the money coming from the state to the counties to provide mental health services to folks that live in their jurisdiction. So this is what the MHSA looked like before, right? So all this money comes in from this income tax on millionaires. The state takes a little bit off the top and the rest goes to the counties. So this was prior to Prop 1. And then, like I said, there were just very broad rules to the counties over how to spend that money. 76% had to be for programs or services that fell into quote unquote community services and supports. 5% could be used for innovative programs and 19% for prevention and early intervention. Within those categories, there were some subcategories and mandates about certain programming and where the money went. So what did the MHSA fund? Again, you can read this slide at your leisure, but we're looking, you know, that big piece of the pie, that big red one, CSS, was full service partnerships, which is intensive case management, but it also came with an entitlement to almost like a welfare for people with serious mental illness. You could get resources of food, clothing, and shelter in an FSP. You were most likely to get housing in an FSP. You had greater clinical encounters, right? There was a greater intensity of engagement with you in an FSP. So CSS, about half of it had to be 51% had to be for full service partnerships. And then there's general systems development. And this is a broad category, but I think what's really important for local stakeholders to know is that what's in this category is actually a lot of clinical treatment infrastructure. So in Sacramento, there's 60 beds of crisis residential, which is 90 days, step up from a step down from a hospital or step up from the community and avoid the hospital. 60 beds, and those programs are funded out of CSS GSD. We have the mental health urgent care clinic, which is open 24/7, where you can walk in and without having to go to an emergency room, immediately see a psychiatrist, a psychologist, a clinical social worker, peer support. That's CSS GSD funded. So when we talk about, services through the Mental Health Services Act are being cut, we're actually talking about, buildings and staff and programming, especially in GSD, that could be on the line. There's also outreach and engagement and housing funded through the MHSA, and housing means two things primarily. It means whether your county was involved in building permanent supportive housing or rehabbing permanent supportive housing or leasing it. And then the other one was folks that have MHSA housing vouchers. So kind of like Section 8, you have a market rate or semi-market rate housing voucher that you can go spend wherever you can find a place, an apartment to live in on your own. PEI, a lot of this is more focused towards youth for obvious reasons. And then we had innovative projects. And so that's basically those are the broad categories that MHSA required in funding. And this is what Prop 1 did. So first of all, it took quite a bit more, took twice as much off the top for the state. So now we've got about 10% going to the state before money goes to the county. So there was a funding loss there. Then what goes to the counties, there's different mandates on how to spend it. So you're looking at FSPs are a mandated spending of 35%, housing interventions is 30%, and behavioral health services and supports is 35%. So it changed those big allocations. There are sub-mandates within it. For instance, half of the housing interventions money has to be spent on those meeting definitions for chronic homelessness. So there's all kinds of new mandates within the broad funding allocations. I like this graphic. This is straight out the bill analysis for the MHSA. And so really what you're seeing is especially the CSS, this community services and supports bucket. It's going from 76% of what counties have to spend money on. And you're seeing it cut all the way down to about 17%. So, and the reason for that was to make room and shove more money into what's called housing interventions. So if it wasn't already obvious to people, what SB 326 and Prop 1 did was not increase funding, but divvy it up differently. The pie was cut up differently. And the different way that the pie was cut up is going to force big service funding cuts for serious mental illness for adults and children at the county level. So here's the new, here's the same slide updated. So one of the things the state did is prevention and early intervention. They axed prevention. They said prevention is a population-based, sort of education-based thing. We're going to let the state do that, and that money is going to go back to the state. So that was part of the change. So we're no longer doing prevention with MHSA dollars. It's now called the BHSA. Outreach and engagement, innovation, all the mental health, outpatient treatment and services, and all the SUD are now being in this bucket that went from 76% to 35%. So you're looking at deep cuts. FSPs came out of this bucket and became its own thing. And we don't know exactly what they're going to be. They have a definition now in the MHSA, but it lives in the regulations, which can be sort of changed by the Department of Healthcare Services in an informal way. So we don't know exactly what an FSP is going to mean going forward. What will the eligibility requirements be to be in an FSP? What kind of services and supports and resources will be in an FSP? We only have the old model. We don't know what they're going to do yet. Housing interventions, we don't quite know what it means. They didn't give it a legal definition, so we're not sure. We're not sure how much of what the counties are doing now in terms of housing with MHSA dollars is still going to be an allowable expenditure. when the new regulations get put out. So it's a quandary. We know rent vouchers are explicitly still allowed, operating subsidies. We don't know to whom for what. Capital infrastructure, meaning the counties can build permanent supportive housing with these dollars again, but there's a bunch of restrictions on it, like when and what to some extent. You know, housing navigation may be paid out of this. So does that mean it's, you know, are these housing dollars going to pay the salary of someone who's helping you find housing? We're not totally sure. And then a big question is the court ordered stuff, because the MHSA by regulation is designed for voluntary participation. There are various other regulations that prevent it from being used for institutionalization. So what we mean by that is more than a short-term hospital stay when you have no insurance payer. That's all MHSA allows now for involuntary clinical treatment facility stays. You have to be it has to be a short-term hospitalization with no insurance payer, then the MHSA can pick it up. Explicitly long-term clinical treatment facility stays are not MHSA fundable, right? Under the old schema. So the big question with the Behavioral Health Services Act is how much of this housing money can go to clinical treatment facility stays? And can those be court ordered, right? So how much of a system that was really by regulation had to be designed for voluntary participation by culture mostly has maintained that. AOT did dip its hand in, CareCourt did dip its hand in. They probably should have been sued. They weren't. But, you know, for the most part, MHSA has been preserved for, you know, non-law enforcement and all voluntary services, and we just don't know what's going to change there. We're not quite sure what population-based prevention means just yet, and what the state is going to do with its new cut off the top 3% for workforce. The BHSA also has a planning process. They have to do a 3-year integrated plan. So what that means is previously the counties would plan for their MHSA dollars as a sort of standalone item. There's an MHSA steering committee. There's the local mental health boards. There's the community planning process where stakeholders can come and say, this is what we want funded. And that, so all the Mental Health Services Act money was planned for and budgeted and did its whole thing separately from any other budgetary planning process or budget spending from the county. That's changing. So now Behavioral Health Services Act dollars, or formerly MHSA dollars, are going to be part of a larger plan, an integrated plan that includes all the funding sources to the county for behavioral health or SUD. And I can't believe that I failed to mention, I'm going too fast because there's too many laws, but I will say too, the other big change to the Mental Health Services Act was it was opened up. Previously, it could only be used for serious mental illness for adults and children. Now it can be used for moderate to severe substance use disorders. So that also is going to be affecting the picture of programming and funding, because obviously, you know, it's not just that going back, whoops. It's not just that we cut up the pie differently. It's also that sort of hidden within, you know, this cutting up of the pie differently is it's not a mandate, it's an option, but there's a lot of pressure for the counties to do it. So, you know, you're going to see cuts to serious mental illness program, but they're also trying to bring online services and programs for people who only have substance use disorders. So, you know, unfortunately, what they really did was put people who only have serious mental illness and their families sort of in competition with folks for funding with folks who only have serious substance use disorder. So, you know, again, that's going to affect the picture at the county level of changing, you know, programs and services. So we have the new integrated, another big concern, and obviously we, you know, were some of the longtime peer support providers, longtime peer support trainers, longtime peer support advocates. So we're looking with the changes to the BHSA. One of the big concerns is that peer support is going to be severely impacted, if not go away, at least in some counties. Peer support is where persons with serious mental illness or family members of persons with serious mental illness become providers to each other, and they are Medi-Cal billable, and they can provide a range of services to the client. We have the Medi-Cal certification was only brought online in 2020. We were the 48th state in the country to get a Medi-Cal certified peer support at the state level. So we were way behind the curve on that. And as you can see, it's only 2024. So essentially this is brand new. We just got this. We have about 2,800 people that have gotten the Medi-Cal certification. They can bill Medi-Cal for peer support services. We have an unknown workforce that are uncertified peers. So they're providing peer support, but they don't have a Medi-Cal certification, so they can't bill Medi-Cal. And right now, regardless of which camp you're in, that money to provide that benefit is mostly coming from the BHSA and the MHSA. And it is a discretionary benefit to Medi-Cal beneficiaries that's only in specialty mental health. So this benefit of having a peer support worker is only available to adults with serious mental illness in the specialty mental health system, and it is not on the non-county side of the house, the managed care for Medi-Cal called CalAIM. And the counties can opt in or opt out of providing this benefit to their Medi-Cal members. And it's really important. It changed my life. It saved my life and so many others. And it's threatened by Prop 1 because it's a discretionary spending item. And there are so many new mandates and funding shifts to the counties that they may either opt out fully or simply defund this Medi-Cal benefit. So that's a big concern. And if you are a peer support worker, or a person who's benefited from peer support, this is something that you might consider advocating for at the local level, that your county not cut funding for peer support workers, especially because we have a massive workforce shortage in mental health. So what's the status of the implementation of most of these things? So SB 326, the Prop 1 election results were only certified about 2 months ago. Those changes in how counties have to spend money don't officially take effect until July 1st, 2026, right? So that's when the funding shifts happen. However, the MHSA 3-year plan cycle, we use 3-year plans, is ending at the end of 2024. It's ending in December. So now counties are in the awkward implementation phase where they know they're entering a new 3-year cycle for 2025, 2026, 2027, 2028, I think is how that will work. But in any case, they're going to be about, 2 years where they're still under the MHSA mandates. And then all of a sudden, July 1st, 2026, they're under the shifted BHSA mandates. So between then and now, they have to change all of their programs and decide what they're going to cut and what they're going to keep and what they can cut and keep. So government stakeholders are already privately planning and meeting. That's overwhelmingly the Department of Healthcare Services, which is the regulator for the BHSA, they get to make regulations, which are a form of law, right? They're the form of law that puts flesh on the bone. So DHCS has an enormous amount of latitude and ability to put flesh on the bones of the BHSA and direct how money can be spent, what the law means to a certain extent. So they've been planning with the entities that there are a number of sort of trade organizations that represent all the counties or local governments. So the County Behavioral Health Directors Association is one, and they're working closely with DHCS to try to figure out how the heck all these different counties are going to take their existing budgets and programs and services structure and regulations and jam it into a whole new schema. California, as of the 15th, has launched some new websites specific to Prop 1. So we're looking, one is simply mentalhealth.california.gov. Another one is called behavioral health transformation, which is a new phrase they're using. So those two websites are listed. And then if you're someone who wants to see the decisions that DHCS is making, essentially new regulations for counties that they're going to have to make well in advance of July 1, 2026, you can sign up to get alert notices from DHCS. They're called behavioral health information notices or plan letters, BHIN or plan letters. So, if you get deeply involved in what's going on at your county level and you need to understand the lingo and you want updates from DHCS, you can sign up for their listserv and get updates from DHCS. So that's one source, one place you can go directly for information about new regulations related to Prop 1, facilities, anything that might be happening. DHCS is also hosting stakeholder listening sessions about the implementation of Prop 1. They don't announce them very far in advance, and it doesn't seem like they have a listserv. They've held 2 so far. They are only holding them until October, and they don't announce in advance exactly what the topic is going to be. And I went to one that was yesterday regarding 3-year plans and what sort of data points should be in reporting about 3-year plans back to the state. And honestly, they were very basic. And their scope of feedback that they want from the public was very limited. So I don't know if that's the best source of information, but it is one thing that's going on related to Prop 1 implementation, a place where you can offer your comments. These were the prior rounds. They did a listening session about how to spend what facilities to build with behavioral health continuum infrastructure grant money from AB 531 and Prop 1. And then yesterday's was the 3-year integrated plan. Those sessions have been recorded and they're at that website address. Other places, if you're not familiar with policy, other major places where Prop 1 is being discussed, you can offer public comment, or it's a good source of information because the government tends to dribble out information. Even all of us advocates are saying, you heard what? Where'd you hear that? So, it's not terribly organized on their part, but I find that oftentimes, if DHCS or somebody is presenting at one of these types of meetings, that's where you'll get a lot of information that you can't find another place. So there is the Mental Health Services Act Oversight and Accountability Commission, the MHSA OAC. You can go to their meetings and make public comment. And there has been quite a bit about Prop 1 there. There's behavioral task force meetings. There's the website for that, and there is a listserv. And the CARE Act Working Group, which is the CARE Court Implementation Group, they also seem to have information, and there is a listserv there. And so, just broad, again, I mean, I've sort of bounced around in quite a bit in information because I'm trying to give a broad overview and drill down later. But, what exactly does implementation of Prop 1 entail at the highest level? There need to be some high level decisions and regulations, meaning essentially, just more particular, smaller laws to implement from DHCS. And broadly, we know what some of those are. They need to decide for prevention and early intervention, how will prevention be split off from early intervention, and what kinds of, formerly quote PEI programs are going to still be able to be funded, and what kind of activities you have to do in that program, for your program to be funded. Full service partnerships. It sounds like it might be a total makeover. Right now, like I said, it's intensive case management. It's also resources, food, clothing, shelter, and a certain level of engagement. But it seems like they may go back to the drawing board. And so we don't know, what are the populations that you're trying to serve with FSPs? What are the evidence-based practices that we're going to are part of the services or programs for an FSP? Like, what's it going to mean going forward? Even more, housing interventions. What's a housing intervention? It was not defined in the law. Obviously, they gave themselves the permission. Essentially, they opened the door to allow BHSA funds, as cannot happen now, to be used for long-term clinical treatment facility stays. But in order for them to really be able to do that, they have to issue new regulations, and they have to change existing regulations. So, you know, it's really going to be in the regulations where we find out what the heck is getting funded in terms of housing in a housing intervention. And, you know, if what you want to see happen is, you know, want voluntary rehab stays of, you know, 6 months to a year and a half, to be something that can be paid for with housing interventions. That's where you want to do local level advocacy. It will go back up to the state, even though DHCS might not invite you in the room. If you're making a lot of noise at your local level, if there are demands at the local level, your local politicians care about those kinds of things. So there's a lot here that's unformed, and there's a lot of opportunity for advocacy, because what the heck's a housing intervention, and what are those new regulations going to say? Does the housing spending money in the BHSA have to pair with whatever we're building in the bond, or are they totally separate? We don't know. And again, like I said, regulations are like, you know, almost as important as anything they pass through the legislature. And there's a lot of opportunity for people to make their voices heard. And then county level decisions. So those are high level state decisions that are going to come from DHCS, but that doesn't mean you can't advocate at the local level and have your voice go back up the chain. More county level decisions. What's up to your county? Within the new requirements of the BHSA and whatever new regulations are going to issue, it is the county that's going to decide what programs and services that they currently fund with MHSA dollars will be cut. And also what new programs and services will be funded. They get to decide, the county gets to decide, and actually should have put it on this slide. The county gets to decide if it is, oh, I did put it on the slide, if it's going to fund substance use disorders. There was no mandate because there was no new money for the counties. They couldn't mandate the counties expand programming with no new money. So when they divided up that pie differently, they made it optional for the county to have programs and services funded with BHSA dollars for moderate to severe substance use disorders for adults and children, but whether they do it is up to the county. That's a county level decision. There will be a lot of pressure from the state to do it, but it's still a county decision. Also, within, I'll scroll back a couple of slides because I tried to make it as simple as possible, but this was like really a massive law. But so within these new funding allocations of housing interventions, FSP, and community services and supports, behavioral health services and supports, they actually, because the county said, how can you be so rigid with us? Like, our county doesn't have a lot of homeless people. We're Shasta County. We just don't have, why should we have to spend 30% of our dollars on homelessness when we only have 25 homeless people? So what the state did in response is they will allow counties to temporarily shift some funding around between these buckets. It's up to 7% out of one bucket and into another. So it could be 7% out of housing and into FSPs or vice versa. And you get to make 2 shifts. So whether your county is going to seek any funding shifts to try to save some programs that would otherwise be cut, that's up to the county, and that's an opportunity for local advocacy. Say, you know, if they're telling you if your kid's in an FSP with a serious mental illness and they've been in it for 5 years and they're gonna, you know, they're no longer gonna have an FSP service, you know, one of the things you could advocate for is say, hey, if you don't have enough money for FSPs, move it out of a different bucket. So that's an opportunity and a local level decision. And then who are the local level decision makers? Board of Supervisors, mental health director, mental health boards, AOD boards. I mean, the boards are advisory. They're not direct decision makers, but they are folks who hold forums and have knowledge and, you know, where you can engage. And obviously local elected officials as well. And state, for that matter. You can certainly complain to your state senator or assembly member about anything you don't like about what they passed as bills that ended up in Prop 1. And then timelines. This is really important. I don't know that every county is adhering to this. This is informal. I took this slide from a presentation by Sacramento County. So even though those funding shifts for Prop 1 don't take effect until July 2026, how soon do counties need to figure out what they're cutting and keeping out of existing programs? And it looks like they're trying to make those decisions very quickly. So Sac County, they're saying between March of 2024, which was, 2 months ago, and December, which is only, at this point, about 6 months away, they are making the decisions about what services will be cut or defunded. I mean, you can see there the language that they're using, and also what new services they might bring online, right? If they're going to expand to SUD. Now, for them to be able to do that, that means the state has to put pedal to the metal and issue some regulations fast too. So I say all this because, Access is a brand new program, so we haven't been, this is our first time presenting on this. But if you want to save programs at the local level, you need to act quickly, because these decisions are being made in a very quick way. I imagine they will go through revisions. You never get something right the first time, or the community gets upset if something gets closed that was valued. So I imagine there will be lots of advocacy and struggles going on and different things changing for a number of years. But at least these initial decisions about what county level currently MHSA funded programs are getting kept or cut are coming up. Okay, that was a lot of information, and I apologize. Some of it was a little disorganized in the presentation, but I imagine many of the small number of folks on this call are pretty familiar with this stuff anyways. And then I'll just zoom through kind of what's going on this year. So all small potatoes compared to what happened the last 2 years, really, with CareCourt coming online, and then the changes to involuntary holds and conservatorships in Prop 1. We're looking at more, I mean, they just kind of keep coming with the expansions of involuntary stuff. So SB 402 from Senator Wahab is a bill that would allow psychiatrists, psychologists, social workers, marriage and family therapists, nurses, licensed professional counselors, all those folks in their private practice, to write 5150 psychiatric holds. Currently, they can't. At least as the law has been consistently interpreted for a number of years, you can only write a 5150 hold if you're designated by the county and you're attending staff at some type of facility, or you're a mobile crisis, or you're a cop. So this would expand it to an unknown and large number of practitioners in their private practice. It was advertised as getting law enforcement out of writing holds, but it still relies on law enforcement because the provider has to call someone for transport to a mental hospital if they are placing a hold in the community. We don't have real alternative transport, so Cal Voices, no, not the Access program, but Cal Voices is opposed to this bill because we think that it leads to greater law enforcement involvement and providers profiling their clients for potential dangerousness and quote unquote need to have the police if they're placing a hold. So Cal Voices is opposed to this bill. This is actually a very important bill. I shouldn't have said this one was small potatoes. Right now, this goes back to the question of, okay, people with only a substance use disorder can now be, placed on a 5150, placed on a hold by police on the streets, acutely intoxicated, addicted, maybe medically fragile. Where are they going? This bill purports to address that because they never updated where someone would go. So the law still says if you're getting put on an involuntary hold, you can go to a general acute care hospital that is specially regulated to provide psychiatric care. You can go to a psych hospital, or you can go to a crisis stabilization unit. This bill is very weird. I don't know why anyone would do this. We'll put it that way. Essentially, this bill purports to say that folks with substance use disorder can go to basically anywhere without updating the regulations for that place to be a place that's safe to treat you. So there's something odd going on. DHCS did issue regulations saying if you're being put on a hold for substance use disorder, you should go to where you can go, where we think it's fine for you to go is somewhere that qualifies as a chemical dependency recovery hospital, even if that's a subpart of a psych hospital or a general acute care hospital. What this does is just kind of say, well, you can go anywhere. We can send folks who are involuntary SUD patients to psychiatric health facilities and to mental health rehabilitation centers and to social rehabilitation centers and to skilled nursing facilities. And this is ludicrous for a number of reasons, one of which being most of those facilities are not locked type facilities. PUFs and MHRCs can be locked facilities, most are not. Social rehab facilities are categorically unlocked facilities. Skilled nursing facilities are largely, unless they have some special subtype, they are unlocked facilities. So this bill is really wild. We don't exactly know what's going on. They also purported to tell DHCS that they had to allow admissions to some of these places. And these are, I mean, one concern is this is mostly unlocked infrastructure. So there's obviously an incentive to the counties to take a bunch of unlocked infrastructure that is serving one segment of the population, throw a lock on the door and convert it to be used for involuntary SUD treatment. This is advocacy that can happen at the local level. If you are concerned in your community about your skilled nursing facilities, that you don't have enough, and the state is creating an incentive, conjoined with a lot of political pressure to throw a lock on the door of that skilled nursing facility, kick everybody else out and use it for SUD, that's a major concern. Cal Voices is opposing this bill, and because, and so is the County Behavioral Health Directors Association, so is the Association of Social Rehab Facilities. No one's really sure exactly what's going on, but this, it doesn't portend well. It looks like one of the ways the state wants to solve the problem of having inadequate numbers of beds to involuntarily treat large numbers of people with SUD is to convert existing infrastructure. And again, this is something that will happen at the local level. Even though this is a state law, it really kind of kicks it to the counties to decide what's going to happen to the infrastructure in their county. So this is a good opportunity for local level advocacy. And you can, there's more information there. You can review those slides at your leisure. There's another bill that has mostly been amended back, but there was another bill that would have removed the right to have hearings regarding involuntary medications in mental hospitals. Cal Voices opposed that bill, as did ACLU and many others, and most of those hearings have been returned. But again, over and over again, the pattern that we see is well-established legal procedures, fundamental rights are being taken away, or there is an attempt to take them away in a systematic way. Another bill that was potentially very impactful for the mental health community was SB 1196 from Senator Blakespear, which would have been the largest expansion of the aid in dying law in the United States. And it would have allowed assisted suicide for mental illness in the event that it was, I forget the exact phrase, irremediable and something else, but not deadly. So we had concerns about this bill, not on a values level related to when people want to make those kinds of choices, but there were no protections in the bill to prevent it from being used in a bad way and against someone's will. So we opposed that bill, and it actually died in committee. A lot of people opposed it from the disability justice community. Okay, that was a heck of a lot of me talking, and I am now going to see if I can expand where I can see everyone and hands, and see if folks have questions. Give me 1 second to just get myself situated with my technology so that I can see hands and call on people.
You are unmuted.
Okay, I think I can see.
Okay, I think I can see.
I need to mute myself when I unmute.
I need to mute myself when I unmute.
Tiffany, do I need to?
Tiffany, do I need to unmute?
Tiffany Elliott.
Tiffany Elliott.
Hi.
Hi.
Oh,
Hi. Oh,
mute your phone. There you go. Yeah, thank you. I did want to ask if the slides will be available after this, presentation. There's so much good information, and some of it was quite small on the page, and I'd love to be able to go over it in more detail. Is that something we'll be able to have?
Yep, we're absolutely sending out the slide deck. Yeah, I know it was a lot of information, kind of rapid fire, and not the best organization necessarily, but yes, the slide deck will go out. And if you have questions, let us know. I should also have mentioned, this was kind of the broad take. We are trying to do another quarterly policy update early into the next quarter, and really drill down on Prop 1, because those deadlines are coming up fast and this stuff really matters to folks. So, but information is coming out of the state slowly, it's coming out of the counties slowly. But we want to be on top of it and give it to you guys, so that you have an opportunity to go try and, get a word in edgewise with your counties.
Thank you. I did have a question about the actual content as well. So you were talking about monies being able to be moved from one bucket to another just twice. And in my understanding that that's temporary, that's not something that counties will be able to do in the long run, just a temporary measure.
Oh, great question, Tiffany. No, it's a temporary permanent. So what that means is, basically, the county has to come up with a plan that's going to span 3 years. And at any point during that, I think at any point, I have to review the reg, but or the law, but during that process, the county can request from DHCS. They can say, look, we don't have a lot of unhoused people right now. We want to move 7% out of housing interventions and into FSPs. Will you let us do it? DHCS gets to say yes or no. If DHCS says yes, then that money is moved for the rest of that plan cycle. So, what would happen is, so in that sense, in that sense, it's temporary, right? Because DHCS will approve the shift, and then that shift will remain in effect for the plan cycle. So for 3 years, or if you did it halfway through the plan for 1.5 years. And then the ability for counties to request that funding shift, that never goes away. It's just that DHCS gets to say yes or no with the next plan cycle. Does that make sense? Sorry, it's a little complicated.
Yes, thank you. And what is the deadline for this first, for I know that there was a bit of a call to action on that specific area. When was that? Because I know that you're saying it's all kind of up in the air, but there's a basic outline of time.
Yeah, it's not exactly clear what the state is requiring from counties. I will say this is what happened in Sac County. Sac County has made a new plan for MHSA spending that's going to span the first 2 years into the next cycle until that July 1, 2026 date comes up, when the funding suddenly changes. But they have to plan, right? You can't just shift on a dime. So, it's never been super clear. All right, when does the state want the counties to have made their decision as to what they're going to cut or keep? It looks like, at least for Sac County and probably for others, December this year. When do the counties have to request that flexibility to shift funding from the state? I'm not sure on this first cycle, but it's a good question to ask DHCS. There is a email address. I think it's Behavioral Health Transformation or something. It's on one of the slides. There is actually an email where you can ask DHCS questions like that. And I'm sure if we all do, we'll come back with a lot more information, but I'm not sure how much in advance the state is going to require that the counties make this request to move funding around. I just know that this thing's moving pretty fast, and that shifting funding between buckets is one way to try and save some programming.
Thank you so much.
Yep. Any other questions?
You are unmuted.
Claire, can you hear me?
I can.
I can.
Okay, Claire, really thanks for your efforts today. If I heard a mantra being said over and over again, that we're not sure how the plan is getting implemented and there's no facilities in place. What a mess. Just rhetorically speaking, for our culture, with Cal Voices and MHSA culture, how best to preserve the dynamics of stakeholder MHSA flow, how to best preserve and implement our statewide continuity, our practical lived experience, obviously our advocacy and engagement that's being so dramatically affected. Thanks.
That's a great question. And, you know, honestly, I have had to shift myself from the mindset of, I don't want them to do this, to the mindset of where is there an opportunity for advocacy in implementation? And honestly, I think if the peer community wants to get together and speak with one voice, the people to whom we should speak is DHCS, because they have an enormous amount of power to simply make things up. I mean, I don't mean to be pejorative about it, but usually if you're going to make a regulation, you have to go through something called the Administrative Procedures Act, and it's this whole long, difficult thing, and there's no public notice and comment periods. Well, what they did, because so much was unformed in SB 326 in the MHSA bill, is they just kind of punted it to DHCS and said, DHCS can make it up later with plan letters or BHIN, which means there's an opportunity for us to try to shape, you know, either in concert or individually, to try to shape where important decisions go, because DHCS gets to make them in a very informal way. And I think that's the best way to ensure some statewide continuity. Otherwise, you know, all kinds of things have been punted down to the counties when probably they shouldn't have been in terms of consistency across the state. But I mean, that's the best answer I have right now. Mary Jo, do you want to go?
Yeah, I am in on my phone, and I'm wondering if all of those email contacts and websites and all of that stuff is on the slides, or if there is a report going out, if all of that information can be available, because like I say, I'm working, I can't see the slides, I'm working from my phone. And I'd also like to say that I am currently co-chair of the Peer Council in San Diego, and we really are trying to pull an action plan together for, and maybe the statewide advocacy group can maybe come up with some kind of a game plan for the statewide advocacy in the counties to have a guide to what are the questions we need to ask our mental health director, what are the things that we need to push the board of supervisors for, and our legislators. So if we could get some statewide guidance from whoever, like to Cal Voices and to CAP and, you know, those other organizations, so that we can all kind of be on the same page in terms of what we're advocating for at the county level.
So as to your first question, Mary Jo, yeah, all the email addresses will be on the slide deck, and it will come to your email from Access. The team will send it out. So you'll be able to, you know, copy them down or however, and get them. Yeah, I mean, in terms of like the Access program doesn't necessarily tell people what to advocate for at the local level. But we do want to give people the information on how to do it. And certainly in upcoming policy updates, we can make recommendations around advocacy, but some of it is very individualized, right? Like where somebody may come down on what they think is a good policy or what they think their board of supervisors should do. But we are going to, this was a lot of information in one go, and we are going to narrow down and drill down and not talk about so many bills and so many issues, and really talk about the opportunities where folks can try to shape how money is spent.
All right, and I'm wondering if we should do policy updates more frequently than quarterly, seeing as what's happening right now. That would be really wonderful.
Yeah, that's a request I can take back to my leaders. The Access program requires us to do them quarterly, and we do a lot of work to be able to know things to tell to you. So there has to be some spacing in the timing of it, and also some of it is driven by, you know, when is the state actually releasing more information? When are the counties actually releasing information? When is DHCS actually releasing information? That sort of drives some of it too, because until they tell us things, you know, it's not all out there and available. It's a moving target. And so we sort of have to pick it up as it comes and try and represent it to people in a way they can use it. Does that make sense?
And that makes sense. We just need to, you know, be kept up to date.
I hear that. Okay, I'm not seeing any more questions. It looks like I think that we let's see, there's quite a bit in the chat. I'm just going to check the chat really quick and then we can part, but you can part anytime you want. Okay, I think that is it for our first session, and we hope to see you back in the future. And please share it. There will be a recording that's sent out as well as the slide deck, and you're welcome all to share that with whomever and send them to, when we send out the email, I'll let you all know that we can, folks can go to the Cal Voices website. And that is where they can sign up for the listserv to be able to get access emails about our access events, and also receive slide decks and all that business. Thanks, everyone. Have a great day.